We are now recording. All right, so let's start. So, welcome. Good afternoon, everybody. Um, it's a great pleasure to invite Professor Cetin Karaca to talk to us today. It's a first, I guess. We've never had anybody present to our group from Turkey, but it's very exciting to push the boundaries of this series of presentations. A little bit about Professor Karaca before he begins to talk about the endoscopic management of cystic disease of the pancreas. He's a full professor of gastroenterology at Istanbul University at the medical faculty there, and he's had many faculty appointments over the years since he completed his subspecialty training in GI and hepatology a couple of years ago. Won't say exactly how long. And he was awarded the title of associate professor in 2006 and then became a full professor in 2012. As we were talking about briefly while chatting, he completed an endosonography research fellowship at Mass General and at Harvard Medical School in Boston between 2008. And then during that period, he published many articles in various endoscopy journals, authored book chapters, um, and has been involved in research encompassing experimental models of pancreatic cancer, subepithelial gastric lesions. He's researched into optical coherence tomography in GI imaging, and something which perhaps failed to live up to his potential, but the idea of notes of natural orifice surgery. So over the years, Dr. Karaca has published 130 times. He's been cited around 2,000 times. He's known internationally as an authority on pancreatic cancer, benign pancreatic disease, biliary disease, EUS, and interventional endoscopy. And his clinical and research expertise encompasses cystic lesions of the pancreas, which is the topic of today's discussion, liver disease, advanced endoscopic resection techniques. He's boarded by the European Board of Gastroenterology. Nowadays, as he was telling us, he's in active clinical practice, private practice in Istanbul. He mentioned to me right at the beginning today that he's soon off to the United States, and he will be in St. Louis, Missouri, in the middle of the United States for, I don't know, maybe the foreseeable future. Anyway, it's a great pleasure, and I'm going to hand over the microphone to Professor Karaca talking about cystic diseases of the pancreas. Over to you.
Uh, Thank slides,
We
Dr.
can,
Elliott.
yep, we can see.
Can you see my slide?
Yep, we can.
First of all, I would like to thank Dr. Elliott Goodman for his kind invitation, and it is my honor being with you today. I will present pancreatic cystic neoplasms, approach and management. This is my disclosure. As you know, pancreatic cysts are diagnosed with increasing frequency because of the widespread use of the cross-sectional imaging, such as MRI, CT. The incidental cyst rate is generally reported between 2 and 15% in different journals. The incidence increasing with age, improvement in advanced imaging technology, and reading by an expert radiologist as well. Pancreatic cysts may be detected in almost 50% of patients who undergo abdominal MRI for unrelated reasons. As you know, according to the WHO classification, there are four different pancreatic cystic neoplasms. The first one is serous cystic tumors. Second one is mucinous cystic neoplasms. Third one is intraductal papillary mucinous neoplasms. We call it IPMN as well. The last one is solid pseudopapillary neoplasms. Pancreatic cystic neoplasm can also be classified as those requiring or not requiring follow-up and surgery. Surgery may be required in cases of mucinous cystic neoplasia, IPMN, and solid pseudopapillary neoplasia with a risk of malignancy as shown in this slide. What are the risk factors of malignancy? Factors associated with increased risk of malignancy included cyst size bigger than 3 centimeters, finding a solid component within the cyst, main pancreatic duct dilatation, and thickened wall of the cyst, especially in one modality, in one radiologic or endosonography. If you find one of these finding, especially mural nodules, duct dilatation, you have to be careful about risk of malignancy. There was no association between risk of malignancy and cyst enlargement over time. As I mentioned before, a couple of particular, especially size, mural nodule, and duct dilatation is more important than the others. In addition to these factors, the malignant potential of cyst also depends on the cyst type as well. As you know, serous cystic tumors are at very low risk. Mucinous cystic neoplasm, solid pseudopapillary cysts are moderate to high risk of malignancy, and then IPMN, especially main duct IPMNs, are high risk, around 70% malignancy risk. What are the clinical manifestations? Yes, we can diagnose pancreatic cyst incidentally during the cross-sectional imaging, but when a patient with pancreatic cyst apply to us, what kind of clinical manifestation we can see? Most pancreatic cystic neoplasia are detected incidentally, as you know. Serous 1 may cause mass effect, especially they localize the head of the pancreas. Sometimes they can cause mass effect. Mucinous cystic neoplasia may present with abdominal pain. IPMN may be preceded by pancreatitis. Solid pseudopapillary neoplasia present with mass effect and abdominal pain, especially are more common for malignant lesions. Which modality should be used for imaging pancreatic cystic neoplasms? Here, the key challenge is identifying in evaluating pancreatic cystic neoplasms. Initial modality, the first step, the cyst evaluation is to obtain a contrast enhanced MRI and MRCP. Why? We have to assess cyst characteristics, mural nodules, especially thickness of the wall and ductal communication. We can diagnose with contrast enhanced and for patients unable to undergo MRI or MRCP. For example, if your patients have a knee replacement, at that time, a pancreatic protocol CT serves as an acceptable alternative as well. As you know, IPMS are most common cyst type, representing more than 50% of the all pancreatic cysts. They contain mucin-producing goblet cells among dysplastic columnar epithelium. All IPMS harbor malignant potential. Please don't forget. And then arise from epithelial cell lining the pancreas, especially. Sometimes maybe in the main duct or side branches as well. CT scan MRCP can assess surrounding structures, lymph nodes involvement, and metastatic disease. Yes, we can diagnose cyst structures with endosonography. The fault of the endosonography is we cannot evaluate, especially distance metastasis with endosonography. For this reason, CT and MRI are superior to the endosonography, especially evaluating the distance metastasis. Compared with ERCP, MRCP is more sensitive for differentiating mural nodules. As you know, ERCP interventional modality, there are so many risks, pancreatitis, something like that. For this reason, we have to choose MRCP for evaluating a pancreatic cyst. MRCP is also superior for demonstrating the internal architecture of the main duct and the extent of the IPMN as well. There are three types of IPMN. The first one is main duct, second one is branch duct, and third one is mixed type. As you can see, especially on this MRCP, this MRCP shows a dilated, as you can see, a dilated main duct. Main duct IPMN involvement is characterized by a diffusely or partially dilated pancreatic duct. It is predominantly found in the pancreatic head. Malignant transformation rate is up to 65%. First image, as you can see, in pancreatoscopy, papillary protrusions in the pancreatic duct can be observed in IPMN cases, and then especially in the endosonographic examination in this image, a dilated main duct observed. As you know, especially the diameter of the pancreatic duct in endosonography, there is a rule at the head of the pancreas, the maximum diameter of the duct 4, at the body 2, and especially in the tail should be 1 millimeter. Yes. In this slide, as demonstrated in these endosonography images, the malignant transformation of IPMS characterized by increased cyst wall, as you can see. And then the mural nodules into the cyst, especially. Wall thickness and presence of the intralesional mass. Yes, diagnosis can be confirmed by performing fine needle aspiration for biopsy of the thickened wall and the mass. What is the superiority of the endosonography compared to the other cross-sectional imaging? During the examination, you can evaluate mural nodules, wall thickness, duct enlargement, and during the procedure, you can do fine needle aspiration, and then you can get histologic diagnosis as well. Branch duct IPMS is characterized by dilatation of the side branches of the pancreatic duct. In this MRCP, a great cluster-shaped side branch IPMN is observed. It is often seen in pancreatic head or synapse process, especially branch duct IPMN. Malignant transformation is compared to the main duct IPMN very low. We can observe these cases. As you can see in this MRCP shows a dilated main duct and side branches as well, as you can see here. Mixed type IPMN involve both main and branch duct as well. Behave like a main duct IPMN. If an IPMN case has a dilated main duct, you have to these cases very closely because of the malignant risk. Malignant potential is greater than branch duct IPMN, especially in the mixed type IPMN cases. In this slide, as you can see, in CT and US of the mixed type IPMN are shown. In CT, as you can see, main duct is very dilated, and then you can see this side branch dilatation as well. In side branches look like grape-like image. As you can see here, main duct is very enlarged in this case as well. The other pancreatic cyst is mucinocystic neoplasms. Especially mucinocystic neoplasm constitute 10% of the pancreatic neoplastic cases. 90% of them located in the body and tail especially. It affects middle-aged women. They can be unilocal or multilocular, as you can see, especially in this endosonography. This is the unilocular mucinocystic neoplasms. Especially in this image, you can see the septated mucinocystic neoplasms. There is no connect. In these cases, as you know, there is no connection with the pancreatic duct. It contains ovarian stroma and peripheral eggshell calcification. Especially this kind of findings especially predicts cancer as well. Mucinocystic neoplasms cross-sectional imaging, as you can see here, especially in the CT, appear as septatic cystic lesions. They contain eccentric calcification, larger size, larger than 5 centimeter, thickened or irregular cyst wall, internal solid component or calcification of, especially very important in terms of the malignant transformation. Thick cyst wall, mural nodule, and mass within the cells, as we discussed before, as seen on this EOS images are indicators of malignancy in mucinocystic neoplasms. You can see the thick wall and mural nodules and mass in the cyst, especially marked as a malignant transformation. Now we will discuss solid pseudopapillary neoplasms. They are usually seen before the age of 35. 80% are symptomatic. They are usually located in the tail and body. Their treatment is easy. They don't need any Whipple, something like that. You can cure them with distal pancreatectomy. They contain component classification can be observed as well. As you can see here, there is a calcified mass lesion on the tail of the pancreas. This is the endosonographic image, especially in the pathologic examination. You can see the small cystic and solid components as well. Solid pseudopapillary neoplasms appear as a mixed, especially on the, as you can see, cyst and solid characters with the calcification. They are very well demarcated solid tumors. Serocystic tumors, as you can see, the risk of the malignancy is very, very low. You can find a couple of case report, especially in the PubMed, very well demarcated multicystic lesions, as you can see. A central scar or sunburst calcification is considered pathognomonic, especially in the 20% of the cases. As you can see here is the central scar, especially in the CT scan, you can see the calcification and the central scar in the center of the lesion. As I mentioned before, malignant potential is very low. As EOS can more closely characterize pancreatic cystic neoplasms and also allows aspiration of cyst fluid. This cyst fluid obtained via EUS FNA can be analyzed for cytology, EOS guided through the needle biopsy, tumor markers, CAA, glucose, diagnostic molecular markers, and then prognostic molecular markers we can get during the endosonographic examination with FNA. Cyst fluid cytology often yields a paucicellular specimen, limits the yield of the cytology, especially. Cytologic examination of the cystic fluid may permit diagnosis as well. For example, glycogen-rich cells for serocystic neoplasms or mucinous-containing cells for mucinous-cystic neoplasms and IPMS, but the sensitivity is low. The addition of the cytology brushing may improve the yield of the EUS FNA for diagnosis of the mucinous lesions. Especially, there are so many studies about tumor markers. CA is the best studied and most accurate tumor marker for the diagnosing mucinous neoplasms. This study was done in Mass General Hospital. I am a co-author of this study as well. Almost 200 patients who had pancreatic cystic neoplasms surgically resected reported that a cutoff 110 nanogram milliliter had a sensitivity of 80% and specificity of the 98% for diagnosing a mucinous cyst. This, please don't forget this cutoff. It is very important in terms of the diagnosis of mucinous cysts. Intracystic glucose measurement to differentiate mucinous versus non-mucinous cyst has gained considerable interest as it's widely available at low cost, as you know. Low intracystic glucose levels, less than 50 milligram, may be more accurate than CAA for diagnosis mucinous pancreatic cyst. In daily practice, I use glucose level as well for differential diagnosis of pancreatic cystic neoplasms. Mutational analysis, KRAS, GNs, TP53, especially mutation in 1-hyperlipidemia are highly specific for serocystic tumors. Mutation in CT and NB1 are associated with serocystic neoplasm as well. What is the role of the ERCP, especially in the pancreatic cystic neoplasms? ERCP was traditionally used in the evaluation of IPMS. During the ERCP, if you see a patulous and resembles a fish mouth papilla, frequently seen in mucinocystic neoplasm, in IPMS, especially mixed and main duct IPMS. An advantage of the ERCP is the ability to obtain pancreatic fluid for cytology and molecular markers by aspiration of the duct contents or brushing. This is an old method. Nowadays, we don't use ERCP. If you incidentally diagnose a patulous fish mouth papilla during the procedure, you have to get cyst fluid to send for cytology and maybe for other analyses. In the first image, mucin discharge from the papilla and fish mouth, as you can see here. In the endoscopic image. In the second image, the dilated main pancreatic duct, especially on the radiologic image of the ERCP. Nowadays, confocal laser endomicroscopy is a new modality in the diagnosis of the pancreatic cystic neoplasms. During the FNA, you can use this modality as well. EUS-guided confocal laser endomicroscopy via a 19-gauge needle enables real-time imaging of the cyst wall. You can find so many papers about this modality. Imaging patterns have been associated with specific cyst types. The ability to differentiate mucinous from non-mucinous cysts and standard cytology. As seen in these images, different patterns of the pancreatic cystic neoplasms have been identified with CLE. In first image, IPMN, papille with outer epithelium, and this is very detailed, yes, as you can see. Cystic degeneration of the solid pancreatic lesion. We have to keep this. It should not be forgotten that solid pancreatic lesions may be present with cystic degeneration, especially pancreatic adenocarcinoma, islet cells, tumor, insulinoma, glucagonoma, sarcoma. This should be taken into consideration in the differential diagnosis of the cystic neoplasms. For this reason, if you have a suspicious about a malignancy, you have to perform FNA. You have to get cyst fluid or biopsy. You have to be sure about your real diagnosis. Sorry. As you know, solid pseudopapillary neoplasms are processed with metastatic potential, and these patients should undergo resection even when this tumor metastasizes. Especially both mucinous and IPMN are considered premalignant, and therefore resection should be recommended when there is concern for high-grade dysplasia or invasive disease is present. There are a couple of Alternative treatments like ablative treatments for the cyst, especially. Alternative treatments are including endoscopic cyst ablation methods, EUS guided ethanol or chemotherapeutic agents. For example, in the literature, you can find so many publishes about paclitaxel injection for malignant potential cystic lesions, radiofrequency ablation, EUS guided paclitaxel ablation has better cyst resolution rates than other ablation technique. Yes, in the summary, the frequency of incidental pancreatic cystic neoplasms is increasing. Identifying cystic lesions with malignant potential is the major difficulty. The first step in cyst evaluation is to obtain a contrast-enhanced MRI and MRCP. Malignancy-related factors such as cyst size, mural nodules, and thick wall should be determined in pancreatic cystic neoplasms. If malignancy is suspected, perform EUS-guided FNA, get material for cytology and molecular evaluation. There is high risk of malignancy in IPMN, mucinous cystic neoplasia, and solid pseudopapillary neoplasia as well. Resection is recommended for high-grade dysplasia and malignant cases. Never forget that solid tumors may undergo cystic degeneration as well. Thank you so much for your invitation, for everything, Dr. Goodman and the other guys. This is we call it Istanbul Bosphorus, we call it Kız Kulesi. The second one is Galata Tower. Especially in the past, Jewish population during the Ottoman Empire, they live in this neighborhood. We call it Galata. Yes.
Very nice.
As you know, Blue Mosque and Bosphorus Bridge. This is the Taksim Square. A couple of pictures of the Istanbul. Thank you so much.
Excellent. Very, very interesting. I think Wissam, you had a question for Cetin.
Sure.
Yes, thank you, Dr. Karaca. Thank you very much. We are very lucky to have you in our team and to have this lecture from you. Thank you very much. My question, I have two questions actually. First is, when would you suggest to follow up with cystic lesions? For example, side branch IPMN or mixed type. Does it depend on the width of the main pancreatic duct? And my second question is, you haven't mentioned anything about CA19-9 in the blood or in the cystic fluid. Does it have any influence? Thank you very much.
Okay. I want to start with the second questions. As you know, CA19-9, 1990, it is not specific to the malignancy. As you know, especially in the pancreatic cancer cases, the specificity and sensitivity of this tumor markers is very low, especially in pancreatic cyst cases as well. But especially if you get very high, a couple of thousands, C199, you have to be careful, I think, but it is not specific like CAA or especially glucose. Could you repeat the first one? First question?
You're on mute, Wissam.
Oh, sorry. Yeah. So my second
No, I
question.
am here.
Yes. So I was asking my first question because there was, I think, a couple of years ago, there was a paper regarding CE99 of level 183 and above with cystic lesions, would suggest to follow up more. That's why my first question. And the second question was,
But you
when
have
would you
to,
suggest?
sorry, you have to evaluate C99 with other markers, CAA and
Yes.
cytology, with all of them. Yes, please.
Yes, and my second question, when would you suggest to follow up with cystic lesion rather than to operate? Does it depend on the main pancreatic duct size, or does it depend on the involvement of the main or side branch or mixed type? When to follow up
As you
rather
know,
than to operate?
okay, as you know, especially side branch IPMN malignant transformation is very low compared to the other types. For this reason, with the during the follow-up, if you get any clue of the malignant transformation, such as wall thickness, intramural nodules, something like that, intramural mass, you have to aware of the malignant transformation. At that time, if your cyst, side branch cyst bigger than 2 centimeters, maybe you can perform EUS and FNA as well, especially. But in main duct IPMN, you have to follow these cases very closely, especially. For example, for side branch IPMN, every 6 or every year, you can see these cases because malignant potential of this case is very low. But potential is very high compared to the side branches. In this case, maybe with abdominal MRI and MRCP, you have to follow up. If you have any clue of the malignant transformation, you have to perform EUS FNA, and then if you get, for example, high-grade dysplasia, you have to discuss with the surgeon for the surgery. The follow-up of the main duct IPMN is very, very important, I think.
Thank you.
You're welcome.
I have a couple of questions, but anybody else with some questions? So I had a couple of questions that they may be sort of silly questions, but I'll ask them anyway. Why is it that the main duct IPMN lesions have a much higher malignant potential than branch duct? I mean, on a molecular level, how do you explain that?
A very tough question, Doctor. Good. I think, as you know, the transformation, especially, how can I like that, especially in the molecular setting, the epithelial cell of the main duct is, I think, rapid. How can I explain? I'm not sure. So sorry about it. Um, hyperplasia
Anything to
rate
do
is the
with
main duct is
yeah. Anything to do with the degree of
of
I don't
the
know, cellular division?
main is either the side ducts. Yes.
So it may be that the main
Do you
duct.
have a do you have
Yeah.
an explanation?
Me, I don't have. I mean, other than is it anything to do with the rate of epithelial turnover in the main duct? Higher rate of turnover, higher risk of malignant transformation. Is that possible?
Is higher than the side branched epithelial cell. I couldn't find the turnover. I forgot. So sorry. Yes, you are right. I wanted to say the same thing. The epithelial cell turnover is in the main branches is higher than the side branches.
Right.
I think for this reason.
Right. Now, does that therefore also explain why a low glucose level in the aspirate is associated with malignancy? Again, metabolically more active cells, higher cell turnover is associated with malignancy, and that higher rate of metabolism and cell turnover,
Sure.
burns up and consumes more glucose and reduces
Sure.
the level.
Sure. Especially in mucinous cases in IPMN or in mucinous cystic neoplasia, the cells in the cyst consume glucose so much, I think.
Right. Very interesting. All right. What other
Dr.
question I
Karaca,
had? Go on,
I,
Musa.
yeah, I just want to say that Elliot in the faculty, he's in charge of the difficult questions. Don't worry about that.
Right. One other question I had, you talked towards the end and in the summary about beware of the degenerating solid tumor. I assume that a solid tumor of the pancreas degenerating and becoming cystic is more common than a cystic malignancy. Would that be right?
Could you repeat it because of the internet cancellation? So sorry.
Yeah, sure. So you talked about how to tell the difference between a cystic lesion
Yes.
and cystic degeneration of a solid lesion.
Yes. Yes.
So which is more common? Is it the solid lesion degenerating and becoming cystic? Is that more common than the cystic lesions?
I want to give you an example, especially as you know, especially sometimes when you evaluate a cystic lesion with endosonography, you say, yes, this lesion like a mucinocystic neoplasia, but especially the pathology report, when you get the pathology report, they write, this is the neuroendocrine tumor. Especially a neuroendocrine tumor, islet cells tumor can present as a pancreatic cystic neoplasms. You have to be aware of about it, especially in the practice. If adenocarcinoma of the pancreas, if it get bigger and bigger size, at that time, as you know, adenocarcinoma is hypovascular tumor, and there is a huge desmoplastic activity. For this reason, sometimes can get cystic degeneration as well. I try to explain this kind of things about the solid pancreatic tumors.
Okay.
As you know, one to third of the neuroendocrine tumors of the pancreas can present as a cyst.
Right. That makes it confusing. One last question, just in generally. I mean, this is very much at the interface between endoscopy and surgery, etc. In general, is there some competition between the surgeons and the gastroenterologists in terms of advanced endoscopy, particularly advanced therapeutic endoscopy? Just as a general question, beyond just pancreatic lesions, but is this where the two specialties sort of they lock horns and fight?
This is the big problem in our country, especially the surgeons in Turkey are very dominant in terms of the advanced endoscopy. They say yes, interventional EUS procedure, ESD, and ERCP should be under our responsibility, something like that. But normally in Turkey, we follow up, especially American medical guidelines. For this reason, I think gastroenterology practice is really, I think, better than the other countries around Turkey. I can, but I think most of the pancreatic cysts are managed by a gastroenterologist. As you know, when surgeon care a patient, they think, yes, is this patients need to surgery or not? Sometimes, if they see any clue of a very small clue of the malignancy, they suggest surgery to the patients. In my country, I don't know what happened in New York or in Israel. I don't know, but this is the main problem between gastroenterologist and a surgeon.
Right, right. Wissam, what do you think? How does that compare with Israel?
I mean, in Israel, it's different from Istanbul and from the US and from Jordan, where I learned, because surgeons in Israel are not allowed to have gastroscopy or do ERCP, although they have the practice to do that. At a minority of hospitals here in Israel, surgeons offer this kind of service, but not in general, not all. I think the answer to your question would be a multidisciplinary team with every pancreatic case. Surgeons and gastroenterology would have a teamwork and for the benefit of the patient. Yes, as surgeons, we tend to push for surgeries, not because we like surgeries, or we like surgeries, but not because of that, or just because of the potential of malignancy, and we know that the numbers are high. That's why we choose sometimes to be aggressive, especially for the young patients.
Got it. Okay. All right. Before
That's
we wrap up, anybody else?
especially in the academic set, multidisciplinary approach is very important, but in the private practice, everything is changing very rapidly.
Yeah.
Right. Right. Yeah. Anybody else want to make a comment or ask a question before we wrap up? Very interesting. All right. Excellent. Well, thank you very much, Professor Karaca.
I appreciate it for your kind invitation, and then
Thank you.
thank you so much. Thank you for having me.
Okay. And good luck in St. Louis.
I hope so. Maybe we will meet anywhere else. Yes,
I hope
maybe
so. Yes,
at
we hope so.
Somewhere.
or yes, I hope so.
Very good. And just to remind the group, we got one last lecture in the series before we take a break, and it's going to be this Thursday, so 2 days' time, and it's going to be on something completely different. Dr. Steve Schweitzberg, who is the chairman of surgery at the University of Buffalo, big academic department of surgery in upstate New York. He is going to talk to us on a very hot topic on the pros and cons of artificial intelligence as it relates to
Yeah. It's
surgical
important.
treatment. A very important topic.
Very.
So everybody, please spread the word. Thursday, 3 o'clock Israel time. Be there. Okay. And again, Cetin, thank you so much.
Thank you so much. Have a nice
Everybody
day.
have a great
Thank
rest
you.
of the day. And everybody who's asked for emails, we're going to get an email with the link to the YouTube video. Thanks again, Cetin. Bye-bye.
Thank you. Hope to see you here. Bye-bye.
Thanks, Wissam. Bye.